All right, everyone, I want to do a quick video audio check, make sure that you can see and hear me okay. Looks like everything is working perfect. All right, amazing. The chat's working, Q&A is on. All right, everyone. Well, today we are going to cover Pharm Guess the Med. And the first question I want to ask you all is, where is everyone joining from? So I live in South Dakota. My husband's in the military, so we move around a lot. But right now I live in South Dakota in the United States. Love it here. Absolutely love where we live. I've really enjoyed being here the last 4 years. I grew up in Minnesota, went to college in Iowa, and lived in Missouri for a little while. And now I'm in South Dakota. So kind of in the Midwest my whole life. So it looks like Massachusetts, Canada, Nigeria, New York, the Philippines, Mexico. Amazing. I love asking this question. And the reason I always love to ask it is because what unites all of us, everyone who is here, individuals from Nepal, from Texas, from Virginia, all around the globe, is nursing. And I think it is the coolest thing to be a part of, that we are part of this community where our one common goal is to add more nurses and have more nurses, not just in the US, but around the globe. And it's so cool to me. Okay, so we are going to really work on meds over the endocrine system. And I want to really focus on the endocrine system because it's hard, and understanding these medications can be challenging. So my question for you all is, how do we feel about Pharm? Are we like, ooh, I love Pharm? Or are you like, Rachel, Pharm sucks? I probably shouldn't say it like that, but let's just be real. Let's just be honest here. When I was in nursing school, I thought Pharm was the worst thing ever. Worst thing ever. Okay. And so I thought it was horrible. I, never thought I'd figure it out, but I did. I eventually did figure out Pharm. And what helped me with Pharm was like, yeah, I got through school and I was like, I feel like I don't know anything. Felt really nervous for the NCLEX. And then I started practicing as a new grad. And that's when I figured it out. So if you haven't figured it out yet, you're not late. It takes some time, but I want to give you strategies to help you get there a little bit quicker. So what we're going to do is I'm going to put up a description, and I want you to answer in the chat what you think we're talking about. So this is a hormone created by our pancreas that controls the amount of glucose in our bloodstream at any given moment. It helps to store glucose in our liver, fat, and muscles. Without this hormone, we can't store glucose in our muscles or liver, and we can't make fat. Instead, without this hormone, the fat breaks down ketone bodies and causes our blood pH to drop to dangerous levels, leading to DKA. You guys are getting it. Amazing. Yes. So kind of our answer here is, what is insulin? And you guys got it right. So here we're really looking for insulin. All right, let's do another one. This type of insulin is the only type that can be given via IV push or IV infusion. This is so important. So I worked in an ICU, and we often had clients that were really, really bad in DKA. That's kind of where one of my main clients that would come in, that and COVID, right? And so with this, we would only give one type, and you guys got it, regular insulin. It is only regular insulin that I will give through an IV infusion, okay? We are going to typically do it as an infusion. IV push is very, very rare, not very common. We typically are going to do it as a drip. Now, I want to talk about drips for just a minute when it comes to regular insulin. When we do regular insulin, is there a point that we would start dextrose? Like if we've got someone with DKA, we've got them on insulin and fluids, is there a point that we need to start dextrose? Yes or no, and when is it? Someone's like, if they're hypoglycemic. Yeah, so typically when your blood glucose gets to 250 is the policy I've always seen. There are policies where it's at 200, but everywhere I've always worked, it's been at 250. We're going to start dextrose. Why in the world would I give my diabetic client sugar? Why would I give them dextrose? Well, if we're dropping them too fast, when they were hyperglycemic, we can actually cause changes, okay? We do not want to cause that. And so that is why we're going to give dextrose. We don't want to cause fluid shifting too quickly. It can cause damage to the brain, other systems in the body as well. And so we give them dextrose so we don't drop that glucose too fast. They're also more likely to have a hypoglycemic reaction. Now, does anyone know how long it takes regular insulin to peak? This is important. When does regular insulin peak? So its peak, oops, I skipped to the next one. Didn't mean to. The peak is 2 to 4 hours. Why do I care about this? Well, it peaks at 2 to 4 hours, okay? Which means, what is my blood glucose doing at 2 to 4 hours if we're looking at my blood glucose? It's at its trough, and that's why we make sure, like, hey, they have a snack at this point because they are at risk for hypoglycemia. Really good job. Okay, here's our next one. This medication works by lowering levels of glucose in the blood. It's fast acting, starts working in 15 minutes after injection, and peaks in an hour. These are hard. I always thought insulin's not bad actually when you get to the hospital, I don't feel like. It's hard when you are getting tested on insulin. It's probably the hardest one to get all these test questions about. And by the way, if you are joining on TikTok and you're like, hey, this is helpful, I typically go live on TikTok like at least 4 times a week. If you follow us and subscribe, it'll give you a notification anytime we go live. So just so you guys know that, I get asked that question quite a bit. Okay, someone's like, is it Aspart? Is it Lispro? It's one of the two. You're right. We're looking at a rapid acting and we are looking at Lispro. This is a rapid acting insulin. And what it's really going to do is, when would we give it? Let me just start with that. When would I give a rapid acting insulin? What's its purpose? Why might I give a rapid acting? Like, well, what's it going to do for me? Yeah, it's going to bring down the sugar really, really quickly. So we use it for a sliding scale. Wow, I cannot talk. A sliding scale, and it's typically given right before meals. Like, we give it, they're eating. Okay. This medication is used to treat diabetes. It's categorized as an intermediate type of this med and has an onset of 1 to 3 hours with peak effects 4 to 8 hours given sub-Q. Let's see if we can get this type correct. Ooh, okay. Lots of you getting it. Okay, NPH. You are correct that this is NPH. So we've talked about regular insulin. We've talked about NPH. I want to talk about mixing the two. So let's bring this together. Let's talk about how we would mix it. So if we're going to mix regular insulin and NPH, what do we put air into first? Amazing. Tara just said on TikTok, I passed my NCLEX last May using Archer. Thank you and God bless. Oh, I love that so much, Tara. Thanks for letting us know you passed, and welcome to the nursing profession. We're super proud of you. So if we are going to mix NPH and regular, and by the way, I've only ever had to do that in like long-term care settings. I've never in the hospital had to mix insulin. Just going to throw that out there to start with. But what this is going to be is it's going to be Nancy Reagan RN, okay? Nancy Reagan RN. And I actually have a sample insulin and a skin on my desk, and I forgot I had it here. So let me grab it because I'm going to demo this for you guys. Okay. So first of all, I don't have an alcohol swipe. The very first thing I would do, I would take both vials, right? I'm alcohol swiping them. Then I'm going to take my insulin syringe. Let's say I'm going to give 5 units of each. So it's going to be 10 units. I'm going to pull that back to 10 units. Once I have gone ahead and done that, then what I'm going to do, right, is I'm going to put the needle into my, which one first? NPH. I'm going to put 5 units of air. Then I'm going to grab my regular and I'm going to put 5 more units of air. Then I flip up my regular, draw it up. Then I'm going to grab my NPH, draw that up. Now here's what I want you to notice. This is the NPH sample. What do you notice? What does this look like? And I'm going to try to get it where you guys can see it on TikTok too. There we go. It's kind of hard to see, but is this clear or cloudy? It's cloudy. Is NPH supposed to be cloudy? Yes. NPH is cloudy. That is why NPH is the only insulin, because it's a suspension, that we need to roll. Do we ever shake insulin like this? This is just a sample vial. It's not legit. So don't worry, I'm not ruining it. Okay. Do I ever do this? No. I will wreck what's inside of there. It won't work very good. Do I ever want to store it in the back of the fridge? When it's unopened, should I store it in the back of the fridge? No. And the reason why is what? Well, if I store it in the back of the fridge, it could get frozen and then it's no good. Once you've opened insulin, it's good for 28 to 30 days, depending on the type, at room temp, okay? Now, do we want to store it in, like, I have a big bright window right behind me. Should I store insulin there? Would that be a good spot for it? No. Why? Well, the sunlight can ruin and destroy the insulin, and so that it's not as effective too. Okay, so those are the things that we're really kind of thinking about, okay? Now, was seeing it helpful? Was seeing that little demo? I know it's not the greatest demo of all time, but was seeing the visual helpful? That's how I want you to think of it as you are, if you get a test question on it, or maybe if you're going to work long-term care, then you may be needing to mix insulin. All right, here's our next one. The medication is a man-made form of a hormone, insulin, that works by lowering levels of glucose in the blood. This specific type of insulin is long-acting, starts to work several hours after injection, and keeps working for 24 hours. Can be used type 1 or type 2. Yeah, one of you is like, I always mix NPH and regular up. What setting do you work in, Gia? I'd love to hear what setting you work in that you're always mixing it. All right, amazing. You guys got it. This is insulin glargine. If we are talking about glargine, here's my question for you guys. Do we ever mix this? Should we ever mix glargine? No, we do not mix it, okay? We do not mix it. The other thing with insulin glargine, does this have anything to do with food intake? If I'm NPO, if my client is NPO, should they still take glargine? What do you think? Can they still take this med if they are NPO? Ooh, TikTok is saying no. Facebook and Zoom are saying yes. Yes, they can still take insulin glargine when they are NPO. Let's think about this for a moment. When somebody is in the hospital, what happens typically to their blood glucose due to stress? Their body's undergone a stressor. They're in the hospital. What happens? Even when they're sick, their blood glucose increases. So I'm not going to give them other insulin types that go with meals, but I can give them insulin glargine because it is long acting. Okay. That's what makes it safe in this situation. Okay. Amazing. Pamela just got her very first very high in assessment. Whoop. I'm excited for you. Really good job. Okay, let's look at this chart for a minute. I always get asked, hey, Rachel, do I need to memorize this? Do I have to know it by heart? Yes and no is my answer. Here's the thing. When it comes to the NCLEX, memorizing things is not going to be what gets you to pass. People might tell you it is, but it's never going to be what gets you to pass, okay? What you have to do is understand. So what I like to do, instead of memorizing every number on this chart, I just remember trends, okay? I start at rapid acting to long acting, and I know the trends of what onset, peak, and duration looks like. Something to note with long acting is that it never truly peaks. It's just that 24-hour coverage. Again, that's why it's safe to give, even if a client's NPO. Now, if a client's blood glucose is low and they're NPO, would I give the glargine? No, I would hold it in that case. I'm not giving it if their blood glucose is low. But if it is on the higher end, I am still going to give that medication because they probably are going to need that 24-hour coverage. All right, insulin administration. When we give insulin, okay, we're typically going to be giving it sub-Q. And when we give it sub-Q, here's the locations. Now, I will tell you, there's a few of these that I don't use. I have never given someone insulin in their buttock. Why? Least invasive here. I'm not just going to expose my client for fun. We don't want to do that. And so instead, I typically use, the fatty back part of the arm, around the belly button. I have used the thigh before, but the buttock and the back are very, very uncommon that we would give them there. And mostly it's more just not for nerve damage because sub-Q injections are itty bitty. It's more so that like, I'm not going to expose more of my client than what needs exposed. It is already a lot to be in the hospital, have someone else caring for you. They maybe need help bathing, whatever it is, all the things. We don't want to expose them extra if we don't have to. The more we provide client dignity, the better. And that should be one of our focuses. Okay. So what we really want to think about here is rotating sites. Why do I not just use the same site just over and over and over again? Why would I not want to do that? Yeah, it causes what's called lipodystrophy. It's where the tissue gets really, really thick due to scar tissue. And so when that scar tissue builds up, we can no longer give insulin there. Well, why can't we give insulin there anymore? Well, what happens is because there's scar tissue, because that is too thick, it actually can't circulate the insulin through the body. It just kind of stays in that one spot. And now the insulin is no longer effective. Now, something I do want to share with you guys is we do have something called our pharmacology crash course. So if you are struggling with pharm and you're like, hey, this has been helpful, this has made a difference, we have a pharm crash course. It's at the end of the month. I can show you guys how to sign up for it at the very end of where you can go. But if you just Google Archer Reviews Pharmacology Crash Course, it comes up. It is a 10-hour high yield live review. Lauren Korth is who teaches it. She's incredible at pharm. Like she puts me to shame. She knows so much in pharm. She is also a nurse practitioner. So she's more educated than I am too. But she is incredible when it comes to pharmacology. So if you're struggling with pharm, you're prepping for your NCLEX, maybe you're in nursing school, highly, highly suggest looking at that pharm crash course. It gets rave reviews of how much it has helped students. And so definitely something I would look at. To Marion, I will make sure to respond to your email sometime by this afternoon. Okay. We'll probably just email support for you not being able to see something in your dashboard. All right, let's go ahead. Here's our next one. This is not a medication, but I wanted you guys to be able to recognize it after all we've talked about. They're sweaty, they feel fatigued, they're dizzy, they're hungry, shaky, tingling lips, a little confused, irritated, anxious. What are we seeing here? Good. You guys got it. Absolutely. Hypoglycemia. So really what we're looking at here is hypoglycemia. Now, why did I want to bring this up? Because we need to recognize hypoglycemia. We need to teach our clients how to recognize hypoglycemia because this can be fatal if we miss it. And so we want to be very, very intentional here. You know, I've taken care of people who their blood glucose has been in the 20s. Okay. It's been in the 20s. And so because of that, we want to be very intentional. Someone did ask, if I buy and take my NCLEX before it happens, do I get the recording of past ones I can use? We do also have the Pharm Crash Course on demand. So if you want to email me, my email is rachel.taylor@archerreview.com. You can shoot me an email. I will say I give my email to everyone. So sometimes I'm a little slower to respond. I'm sorry. I always try within 24 hours. But you can shoot me an email and I can show you too how to get that on demand. But yes, if you purchase, we can get you the recordings if you take your NCLEX before the next offering. All right, this medication is indicated for the treatment of hyperthyroidism in clients with Graves' disease or toxic multinodular goiter, for whom the thyroidectomy or radioactive iodine therapy are not appropriate treatment options. This medication is dosed once per day. Ooh, I feel like this is a hard one. This is a hard one. Remember, Graves' disease, hyperthyroidism. A lot of you are saying levothyroxine. Levothyroxine is synthetic T4. We do not want to give any more T4, T3 to someone who has hyperthyroidism. Okay, so some of you are saying PTU or methimazole. Either or would be correct. I have methimazole on here, but both of them do the same thing. Really, the goal is that they're going to help kind of lower that T3, T4, make it where the body's not making as much. Because really what it is it is an anti-thyroid medication. And so it just makes it where the client just can't make as much. Now, the thing to think of here is they do lower the platelets. And so we want to make sure that we are teaching for risk of bleeding. So what would we teach? If they have a risk of bleeding, what would I want to make sure I teach? Let's think about it. Yeah, soft toothbrush, absolutely. Fall precautions, all the things. Yes. What about a razor? Electric razor is good. We don't want them using like a straight blade or anything. All right, this medication is used to treat diabetes insipidus, which is caused by a lack of naturally occurring pituitary hormone in the body. It can be given at home via nasal spray. This med may also be used in emergency settings to raise the blood pressure in adults who are in shock. Ooh, what do we think on this one? Yes, I am so proud of you guys. You are getting it, most of you. Some of you are really close. I can see where you're getting them mixed up. Yeah, if you said vasopressin or desmopressin, you are correct. What this med really causes is it's going to cause at the renal tubules, so basically in the kidneys, it's going to cause reabsorption of fluid instead of peeing, because that's what happens in diabetes insipidus, right? They drink like a horse, they pee like a horse. Now, someone just said we can't hear you. Can you guys still hear me? Let me know in the chat. Okay, looks like most of you are still hearing me. Perfect. I'm going to keep going. For some reason, your audio is cut out. Just hop off and hop back in. Okay. So for vasopressin, what it's really going to do, again, we're increasing that water to stay in the body instead of excreting it, okay? Because we don't want them to excrete all their fluids, because what happens, they become hypotensive. We also are going to see, right, if they're really hypotensive, they get dizzy, they get really dry inside, right? Yep, they're dry. Everything is really dehydrated. I kind of think of the desert because it's really, really dried out. All right, this medication is a biguanide used in clients with type 2. This is important. We cannot use it in a type 1 diabetic because they are insulin dependent. This med works in 3 ways. It makes the body more sensitive to insulin, decreases the absorption of sugar through the intestines, and lowers sugar production by the liver. Good. Think of like the most common one whenever you're answering this one. Good. Yeah, it really could be any biguanide. The one I'm really looking for, the one that's most common, is metformin. So metformin, kind of the big thing here is it's going to make it where the body can just utilize that insulin a little better and becomes less sensitive to glucose. It's going to kind of remove some of that circulating glucose that's within the body. Now, we do not want them to take it before a procedure because they can go into lactic acidosis. So we're like, nope. We're going to hold it 48 hours. We also have to really watch the kidneys. Metformin's hard on kidneys, so are dyes. And so we just want to be cautious. We want to watch those kidney levels, and we want to really make sure they're drinking plenty of fluids. The biggest complaint that people have is that they get GI upset. That's why they stop taking their metformin. It's why they don't like it, is they do end up with a lot of GI upset. All right, this medication is a synthetic thyroid hormone that is used to treat hypothyroidism, a condition where the thyroid gland does not produce enough thyroid hormone. The thyroid hormone is crucial for regulating various metabolic processes in the body, including energy production and utilization, body temp regulation, and normal functioning of the heart, muscles, and organs. Ooh, I see lots of people getting it right. Do you guys see the difference now? Earlier, when we talked about methimazole, a lot of you said levothyroxine there, but do you see the difference of how this medication is going to work? So truly, when we think about levothyroxine, what it is it's a synthetic T4, okay? It's utilized because, hey, the body doesn't have enough thyroid hormone, so we're going to give it some artificial thyroid hormone. Big thing here, what happens if they have too much thyroid hormone? Like if we give too much of this, what's going to happen? Yeah, they can actually end up with hyperthyroidism. And so we're teaching them to watch for indicators that they are too sped up. Okay, so we want to have them watch their heart rate. Are they struggling to sleep and have insomnia? Are they having diarrhea? Anything that shows the body has been sped up is that indicator that they need to call their doctor. They also should never just like stop it abruptly. Most of the time, if someone's taking levothyroxine, they are taking it basically for the rest of your life. It's very rare that someone stops levothyroxine. Okay. So remember, levothyroxine is hypothyroidism. Methimazole is hyperthyroidism, which is also known as Graves' disease. Okay. Yeah, they can have a big goiter too. Yep. I actually know somebody who they had a big goiter, and that's how they found out that they had hypothyroidism. And then they were able to get started on meds and are doing great now. All right, this is an oral medication classified as a sulfonylurea, and it's commonly used to treat type 2 diabetes. It works by stimulating the beta cells of the pancreas to produce more insulin, which helps lower blood glucose levels. This medication helps increase the body's sensitivity to insulin and allows it to regulate sugar more effectively. Yes, levothyroxine, they do take in pregnancy. So levothyroxine, they will still take in pregnancy. What they will do though, is they will have to adjust the dosages. A lot of times in like the second and third trimester, it can require different amounts of levothyroxine. So they're going to be getting their labs checked very, very regularly. With any of these meds, yes, they might cause some risk, but we always look at benefit over risk. Mom's going to have levothyroxine in pregnancy. Okay. So if you said glipizide, you're correct. Really, really good job. Basically what's happening in type 2, right, is they have this insulin resistance. And so glipizide really kind of helps with that insulin resistance that is occurring. And with this, it's going to basically just stimulate those beta cells and say, hey, we need more insulin. We need more insulin. And it makes that insulin. The other thing that kind of to think about with this is, can we use this in type 1? Could we use this at all in a type 1 diabetic? Nope. It has to be a type 2 diabetic. Here's just some kind of a table that goes over the main anti-diabetic agents. So we have sulfonylureas, biguanides, and then insulin sensitizers. Those are going to end in glitazone is how I kind of always remember them. So those are kind of just our different categories. You do not have to be an expert. The difference, if you think about how these medications work, so if we think of metformin, okay, that is just going to be oral pill that they're taking. It's going to be given typically just once per day, a lot of times in the morning. It's a lot more common. When we look at our sulfonylureas, it is more triggering the pancreas to make the insulin. The metformin just makes the insulin that's produced more effective, and it makes the body more able to receive that insulin, if that makes sense. All right, this medication is a synthetic corticosteroid medication that belongs to a class of drugs called glucocorticoids. It is used for a wide variety of medical conditions due to its potential anti-inflammatory and immunosuppressive properties. It mimics the effects of cortisol, a hormone produced by the adrenal glands, and can influence a variety of processes in the body. Ooh, what med am I talking about? Wow, you guys are impressive. Absolutely. Here I was talking about prednisone, but really if you said any steroid, you would be right. Prednisolone would be another one. Methylprednisolone would be another one. Fluticasone is an inhaled version of it. Budesonide is another inhaled version of it. What I want you to know here is, what does this do to our ability to fight infection? When we're taking steroids, what happens to our ability to really fight off infections? Yeah, it really lowers that immune response. It lowers our ability to fight that infection off. Absolutely. The other big thing with steroids is, what does it typically do to our blood glucose? We've been talking a lot about blood sugars here today. What does it do to it? Yeah, it increases. A lot of time people on steroids, they are grumpy. They get, that roid rage. That's kind of commonly associated. But the other thing that we see here is They're more likely to get infection. Their blood glucose raises. They typically gain weight. They're eating more. And the other thing too here is we never want them just to DC it really abruptly. I had someone who I took care of who had an autoimmune disease. And when they had their autoimmune disease, they were on steroids for years and years. We were trying to take them off in the ICU, and I'm not kidding. It literally almost killed her every time. We ended up just having to keep her on them, despite all the side effects it caused for her, because we could not get her off of them. Her body just responded poorly every single time. All right, guys, thank you so much for being here. What questions do you have? And someone said, hey, I've loved these classes. Can we get a one session where it's just like one-to-one? Absolutely. We offer tutoring. Again, you can email me. It's rachel.taylor@archerreview.com. I personally don't offer a whole lot of tutoring myself, but I do on request. We have a whole amazing tutor team too. If you don't care who it's with or you have very limited time, you can check out our entire tutor team. Again, if you're joining on TikTok and you're like, hey, this was helpful. Let me answer that question in just a second, Hannah. If you're like, hey, this was helpful, again, give us a follow and subscribe. It should notify you when I go live. I won't be live tomorrow, but we'll be live again next week. We'll be making sure to do some more of these lives. My email is rachel.taylor, so RACHEL.Taylor, TAYLOR @archerreview.com. You can watch this over if you go to our Facebook or YouTube channel. You can find it there. And then Hannah asked, hi, Rachel, did you mention we can do on demand before the end of the month if we purchase SurePass package? So the farm crash course itself is not included in the SurePass package, but a farm review is. Okay, the farm review, there is a farm review included. So if you really want the farm crash course, though, we can get it to you on demand. It's just a separate purchase. It's not included with SurePass. There is just a basic farm review included in our SurePass package as well. Okay, so that is all the time I have for today. I hope I answered every question. If I missed some, because I'm trying to check every single platform that all of you guys are on, which is amazing. We have people on Facebook, on YouTube, all of those things. So if you had any questions, let me know. The farm review, if you want to sign up for the farm review, let me show you how you can do that. So I'm just going to exit out of these slides. Okay, can you guys still see my screen? And it's just like a Google. Can you guys see my Google screen here? All right, so if you just search Archer Review Pharmacology Crash Course, it'll come up right away. It's going to be like the first thing that comes up. And then it will tell you kind of all about it. And it will show you when the next ones are. So the next one is June 15th to the 19th. So it starts just already next week. So it's next week, June 15th to the 19th. It is $75, but it's 10 hours. So $7.50 an hour. It's what I pay for a coffee if I go get one out, which is why I don't get them out as often anymore. And really what she's covering in this is the meds you're most likely going to see on the NCLEX and the key points that you should know about each of those medications. But again, thank you guys so much for joining me. I can go ahead and put this link in the chat if that would be helpful. Let me do that. I just put that link in the chats. I don't think it'll let me put it in the TikTok chat, but I'll try to see if you can copy and paste it. But again, if you guys need anything, reach out to us. Our other email is just nursing@archerreview.com. More than happy to help. We want to see each and every one of you guys reach your goals. We want to see you pass your NCLEX. If you don't have a product yet, I really recommend doing SurePass 90 Day. It's our best product with our RN. It actually comes with a free exit exam as well. Someone said I passed NCLEX using Archer. Amazing. Thanks for letting us know, Red. 7 highs and very highs, 4 past cats. Yes, Sonia, that is a good sign. You should be testing very soon with how good those scores are. Those are amazing. If you're struggling with like intense prep medicine, I would love for you to shoot me an email. Would love for you to shoot me an email. I'm going to get you in touch with our person that leads all of intense prep medicine. Can you send me an email or send an email to nursing@archerreview.com? And then an intense prep does include that farm crash course, by the way. Oh, okay. Okay, you're asking me the question. I thought you said, oh, I'm doing it. And it's not what I thought. Intense prep is really amazing if you want direct feedback from an educator. Sorry, Madison, I misread your chat. How intense prep works is intense prep is going to be everything SurePass has, plus you get 5 weeks of feedback from an educator, and you get the pharmacology crash course included with the plan. So that's the differences between the two. All right, everybody. I hope you had an amazing, amazing day. You could upgrade from SurePass to Intense Prep. Just email support@archerreview.com or nursing@archerreview.com, and I can get you in touch with the right people to get that upgrade done. All right, everybody. I hope you have an amazing day. The reason I did say SurePass is the best for the average student, SurePass gets you to pass. Our pass rate with 4 highs, very highs consecutively on readiness assessments and finishing a study plan is a 98.98%. And that I can, really stand behind if you use the product correctly. So I hope you guys have an amazing, amazing day or night. Looks like some of you are going to bed there in Nepal. It's probably late for you all, but have a great day and we'll see you next time. Bye, guys.